Good evening to those tuning in from the East Coast, and good afternoon to those tuning in from the West Coast. Welcome to the latest session of CAEP's National Grand Rounds. My name is Dan Kim, and I'm an emergency physician who practices at Vancouver General Hospital. I'm also the Point of Care Ultrasound Fellowship Director and a Clinical Associate Professor in the Department of Emergency Medicine at the University of British Columbia. I currently chair the CAEP Emergency Ultrasound Committee, and I'll be moderating today's session, which is focused on practical point of care ultrasound applications you can implement into your practice today. We have three amazing presentations from three POCUS experts who are also members of the CAEP Emergency Ultrasound Committee Executive. Each presentation will be about 15 minutes long, followed by 10 to 15 minutes of live Q&A with our speakers at the very end. If you have a question for one of our presenters, please type it into the chat and we'll try to get through as many as possible after all the presentations. CAEP's Scientific Planning Committee has reviewed each presenter's conflict of interest submission. Dr. Gillian Shepherd has received grant funding from Memorial University. Our other two speakers, Dr. Colin Bell and Dr. Talia Burwash-Brennan, do not have any identified conflicts of interest. I have to disclose that I'm on the medical advisory board of Clarius Mobile Health, but I will not be mentioning any of their products or devices, so this should not lead to any conflicts of interest for this session. No external support has been received for this webinar. So let's get to it. We really have coast-to-coast representation here. Our first presenter is Dr. Gillian Shepherd. Dr. Shepherd is an assistant professor in emergency medicine and the director of POCUS at Memorial University in Newfoundland. She's also the education lead of the CAEP Emergency Ultrasound Committee, and she chairs the CAEP Women in Emergency Medicine Committee. She will be speaking about how to improve your ocular exam with point-of-care ultrasound.
Thank you, Dan, for that very kind introduction. And thanks to everyone for tuning in tonight as we talk about ocular POCUS. I'm Dr. Gillian Shepherd, and I'm an assistant professor of emergency medicine at Memorial University. These are the objectives tonight. We're going to describe how to use POCUS to visualize posterior vitreous detachment, vitreous hemorrhage, and retinal detachment. I'd like to take you into the galaxy. Imagine that you're Ray. You've just spent an exhausting day defending the galaxy when you go to start your night shift. You've got two emergency medicine residents, Finn and Poe, who are joining you this evening. And there's a medical student who introduces himself as C3PO. You take everyone over to triage and you look through the charts to see who you're going to be seeing this evening. Your first case is a Jedi with a bad eye. This Jedi has been complaining of some floaters in the right eye after a particularly difficult training session. Our second case is Mr. Yoda. For the last 5 days, he's been finding that he's got flashes and floaters in the right eye, and today his vision has decreased. He's worried how this is going to impact his ability to use the Force. Our final patient is a princess with poor vision. Princess Leia's noticed that she's got some spider webs and a little bit of blurry vision in the left eye. She's got a big battle coming up. She's worried what might be going on with her left eye. Each of the students takes a chart, and before they go to see their patients, you talk to them a little bit about ocular complaints in the emergency department. Eye pathology and eye complaints make up 3 to 4% of all emergency department visits. Most of the patients we see are worried that they've got a retinal detachment. And in fact, 14% of them will. The medical student, C3PO, mentions that he learned how to use the ophthalmoscope in medical school, but he can't really remember how to use it. He asks if you have any tips. Knowing that when he goes in the room, it's probably going to be like this.
Look to the left, the right, whatever.
He suggests that he may want to try some newer technology, point-of-care ultrasound. Since 2000, emergency physicians have been using point-of-care ultrasound to improve their ocular exam. Emergency physicians are using POCUS for a number of indications, including ocular trauma, posterior vitreous detachment, retinal detachment, central retinal artery occlusion, foreign body detection, and optic nerve sheath diameter. The only contraindication to using POCUS is a condition where putting additional pressure on the eye could cause the patient harm. For example, if you suspected that the patient had a globe rupture. You take a moment to review the anatomy of the eye. The aqueous vitreous that sits in the center of the eye makes it an ideal organ for POCUS. You also remind the students that the retina covers the entire back of the eye and stretches from anteriorly from the ora serrata all the way posteriorly to the optic nerve where it's tethered. Most patients who come to the emergency department with flashes and floaters have a posterior vitreous detachment. This is where the aqueous vitreous separates from the back of the eye, but it doesn't remain tethered to the optic nerve. Sometimes when the posterior vitreous detaches, a small part of the retina will also tear in sort of a horseshoe shape. And finally, what most patients are most concerned about is that they have a retinal detachment, which is when the posterior detachment pulls and also pulls the retina away. The retina will remain tethered at the optic nerve, which is very important for us to recognize when we're using POCUS to detect this important ocular emergency. A recent JAMA systematic review and meta-analysis showed that emergency physicians are really good at using ocular POCUS. The sensitivity and specificity for detecting retinal detachment and vitreous hemorrhage are significant. Using POCUS to look for vitreous detachment is not quite as sensitive or as specific. And you may realize why as we move through the presentation. The materials that you need to perform ocular POCUS are a large tegaderm and a bottle of gel. You need to apply copious amount of gel to the eye, and you can put the tegaderm on the eye as shown here, or some people like to put the tegaderm on the probe and then apply the gel directly to the patient's eye. You're going to select the high frequency linear probe. And if your machine has presets, you want to select small parts or the ocular setting to decrease the power by 50% so that you don't damage the delicate retinal tissue as you perform ocular POCUS. Much like when you're learning to use your otoscope, you want to position your hand so you're supporting the probe either on the nasal bone or the zygomatic arch of the patient. You kind of want to float the probe over the gel on the closed eye. On screen right, you'll see what the image will look like in the ultrasound. In the near field, you'll see the anterior chamber. In the midfield, you see the aqueous and echolucent vitreous. And in the far field, you'll see the retina and the optic nerve. In this image where the patient has slightly got the eye deviated to screen right, you can see the lid, cornea, anterior chamber, iris, and pupil, then the lens, the vitreous, retina, and the optic nerve. When you're scanning for a retinal detachment, it's really important to get that anterior part of the retina. You don't want to miss it. So if you start in the transverse view, as you sweep up, you ask the patient to look up. When you sweep down, you have the patient look down. When you change the longitudinal position, when you sweep left, you have the patient look left, and as you sweep right, have the patient look right. A retinal detachment will look something like this on POCUS. You'll have an echogenic line that appears to be tethered to the optic nerve and to the sidewall of the eye. In this video, we can see a clear echogenic line that's tethered to the optic nerve as the patient moves the eye. This has been described as a taut bed sheet. In contrast, when you're scanning for the posterior vitreous detachment, you want to use dynamic scanning, or if you want a really fancy term for how to move your eye, oculokinetic echography. In the transverse view, have the patient look left and right in a dynamic fashion. And when you're in the longitudinal view, you want to have the patient looking up and down. The vitreous detachment will look like an echogenic line that traverses the posterior segment. And as the patient moves the eye, you'll see that it moves in a fluid-like motion. You really need to have the gain turned up very high to detect a posterior vitreous detachment. In this video, you'll see a very subtle white line in the posterior vitreous. Here's another video where you can sort of see an echogenic line in the posterior segment. And again here. Vitreous hemorrhage occurs when you get bleeding into the vitreous, either from mechanical damage to the normal vessels or in an abnormal vessel in a patient, for example, with diabetic retinopathy. We're using the same technique that we use for posterior vitreous detachment, oculokinetic echography. And what you're going to find is a sort of hyperechoic solution that's in the center of the eye and that moves with eye motion. This has been described as a snow globe sign or the washing machine sign. It's easiest to visualize this if you have the gain set very high. And as you ask the patient to move the eye, you'll see movement in the posterior segment. This video nicely demonstrates a posterior vitreous hemorrhage. Here's another video that demonstrates a retinal detachment that's got an associated vitreous hemorrhage. You can see the nice echogenic bright line that's tethered to the optic nerve, that's got a sort of echogenic material in the center of the vitreous that moves with eye motion. For people who like mnemonics, someone came up with a really nice one for patients who have acute, monocular, painless, non-traumatic visual disturbance, and it's called VIGMO. First of all, ask, are there any abnormal findings in the vitreous? Then, is there any change if you use high and low gain settings? Thirdly, is there any change with eye movement or eye kinetics? And finally, what is the appearance of the optic disc itself and the anatomic relationship of the disc to any abnormal findings within the vitreous? So the students have taken the time now to go see the patients, and they come back to you to discuss their findings. Case 1, our Jedi with a bad eye. He had a perfectly normal exam. Pupils, extraocular movements, visual fields, and fundoscopy were all completely normal. So the students used POCUS, and what they found was a posterior vitreous detachment. You can see that nice echogenic line that moves with eye movement and is very reassuring to the patient. Case 2, Mr. Yoda. His visual acuity was impaired in the left eye, but the rest of his exam was normal. Using POCUS, the students were able to show that Mr. Yoda has a retinal detachment that is associated with a large vitreous hemorrhage. This means that he needs to be prioritized when you're consulting the ophthalmologist. And finally, case 3, our princess with poor vision. She had decreased visual acuity in the left eye. And when she did visual fields, she found that she had a lot of cobwebbing and cloudiness in that lateral aspect of the left visual field. Using POCUS, we're able to see a clear vitreous hemorrhage. What's not as clear is whether or not there's an associated retinal detachment. But if you look closely as this video loops, you can see that the echogenic line doesn't really seem to tether anywhere to the optic nerve. But if you're not sure, you really want to prioritize this patient and get her off to see an ophthalmologist. So the disposition for each of these patients is going to be to the ophthalmologist. What POCUS has helped us do is to be able to give a clear diagnosis and allow our consultant to prioritize how quickly these patients need to be seen. In conclusion, I hope we've covered the following objectives. These are my references. And now I'll hand it over to the dynamic Dr. Colin Bell.
Thank you, Dr. Shepard, for reminding us how none of us are actually able to use an ophthalmoscope with any sort of skill at all in the emergency department. Our next presenter is Dr. Colin Bell, who will discuss two novel ultrasound-guided blocks, the PENG block and the ESP block. He will help us sort out this alphabet soup so you can understand when to actually use these on your next shift. Dr. Bell is an assistant professor of emergency medicine at the Cummings School of Medicine at the University of Calgary. He practices emergency medicine in the Alberta Health Services Calgary zone. He's also the clinical lead of the CAEP Emergency Ultrasound Committee. His POCUS interests focus on competency-based medical education and acute care regional anesthesia.
So I really hope my screen sharing with everybody okay. I'm Colin Bell. I'm an emergency physician in Calgary, as Dan mentioned. And as mentioned before, I don't have any financial disclosures. The support that this presentation has received is really just the emotional support of my family, friends, and loved ones. So I won't be discussing any particular products in this talk and have no additional disclosures to make at this time. Today, we'll be talking about the PENG block and the erector spinae plane block. We'll be describing the indications and processes for performing the blocks with POCUS guidance in the emergency department. So do you perform POCUS guided regional anesthesia in the emergency department? Mabel here on the left really hopes you do. Why? Well, it's opiate-free pain reduction. It prevents delirium. It prevents pneumonia. And in a meta-analysis of over 2,750 patients who got POCUS-guided regional anesthesia for hip fractures, no complications were reported. The number needed to treat of 1 in 14 for delirium is about the same as the 1 in 13 needed for non-invasive ventilation for pulmonary edema. The 1 in 7 needed to prevent a pneumonia, well, that's about the same as the numbers behind steroids for croup. Better than the 1 in 9 for corticosteroids and COPD exacerbations and for antihypertensives and stroke. So why am I choosing to talk about the PENG and ESP blocks today? Well, it's because there's a bony backboard. It's because there's a high impact on the patient experience, and it's because there are no blind equivalents available to us in the emergency department, which is different from some of the wrist blocks and facial blocks that we can do. So things to know before we go. So we're going to talk about our target anatomy, and that'll be the bulk of the rest of the presentation. You need to know about your contraindications and side effects like allergies, anticoagulation, infection or hematoma, or side effects of a particular technique. You need to know your doses. Interestingly, depending on where you live, these are pretty variable. You need to know your complications like LAST, nerve damage, hematoma, or infection, which is pretty rare with shock blocks. And last but not least, you need to know your expectations. So neither of these two blocks is going to produce surgical grade anesthesia, but they both produce a substantial and clinically significant reduction in pain. Before you get started, you're going to need an ultrasound machine. You're going to need some skin prep, skin local, gloves, your block local of about 20 to 30 cc's, a block needle, which is either a echogenic needle, or I like to use a spinal needle, a probe cover or a tegaderm, and a marker to autograph your work and document the time. So the 8 steps to pain relief. You want to set up your room. So you want to make sure you take a 3D problem and make it into a 2D problem by making sure you place the ultrasound machine directly in front of you. So you're guiding your needle into the same plane as the machine with your screen directly ahead. You want to make sure you POCUS landmark before you get started so you can ensure that you can see the proper anatomy. Prep the skin, insert the skin local, cover your probe, put your gloves on, put the gel on, visualize the sono anatomy, guide your needle to the target, and inject the local anesthetic. A hot tip, be sure you know that the patient has had for anesthesia before you start the nerve block. I typically don't perform these procedures on patients who have received anything aside from extremely short-acting opiates like fentanyl. Most of the complications of emergency department nerve blocks aren't actually from the nerve block itself. They're from opiate-related hypoventilation because these blocks work so well. So the pericapsular nerve group block, or PENG block, what do we use it for and why do we do it? Well, it's got a lot of indications that are particularly relevant to us in the emergency department. We use it for hip fractures, pelvic fractures, acetabular fractures, for pain after total hip arthroplasty surgery, and for chronic hip pain. But why do I need to use the PENG block when I can use something like the fascia iliac compartment block? Well, the advantage of the PENG block is that it's a sensory only block. versus a sensory and motor block. And there's a beautifully designed randomized control trial that shows there's no difference in pain management between the PANG and the fascial iliac compartment block after total hip arthroplasty. But the advantage is that there's a substantial difference in motor blockade at 3 and 6 hours. So what does that mean for us in the emergency department? It means our patient with a pelvic fracture will be able to walk and transfer and perhaps even walk out the door. So the PANG block accomplishes its goals by blocking the articular branches of the femoral nerve, obturator nerve, and the accessory obturator nerve. It does not block the articular branches of the sciatic nerve. So that's why some of these patients still have some symptoms. So you can see here on the left side of the screen, the block needle coming in and making contact with the ilium. And you can see the typical courses of the femoral nerve, the accessory obturator nerve, and the obturator nerve as they make their way through the pelvis. For those of us who like to see something in cross-section, this is a Netter diagram with a block needle coming in through the iliacus muscle, going down to the psoas tendon, making contact with the ilium right behind the psoas tendon. It's going over top of the anterior inferior iliac spine, so a key bony landmark, and it's making contact before the iliopubic eminence, another key bony landmark. One of the great things about this block is that you're well away from the femoral nerve, femoral artery, and femoral vein. So, how do we go about generating the ultrasound images? Well, put the probe on the patient in line with the crease in the groin. It's a fairly familiar view for us, for those who are familiar with inserting femoral central lines. Move the probe a little bit laterally and keeping the femoral artery in view. Move cephalad, bringing the ilium into view. What you'll see is the convex femoral head start to disappear with your bony anatomy and become the concave ilium. You'll also see the AIIS come into view and the psoas tendon, as well as the iliopubic eminence. The femoral artery should be on the far side of your screen and you should just be in line with that crease. If you can't see the psoas tendon, what you should do is actually fan the probe laterally. And the tendons have a property called anisotropy. So they illuminate best for ultrasound when the ultrasound beam is perpendicular to the tendon. So as you fan the probe left and right, the tendon should get brighter and darker and brighter and darker. And that should give you a really good idea of where this tendon is lying on the posterior aspect of the pelvis. Once you've got that, you're set up to go. So just make sure you've got a nice clean view of how you're going to get your needle back down behind the psoas tendon. So what does it look like in real time? Well, you can see a needle here coming in from the left side of the screen and making contact with the ilium behind the psoas tendon. You can see the femoral artery here on the left side of the screen. A little test injection of local anesthetic lifts the tendon up and away from the posterior rim of the pelvis. Once you see that tendon lift up and away, feel free to inject more local anesthetic. When you're done, you can withdraw the needle and bingo, bango, bongo. You completed the PANG block. So in about 10 to 15 minutes, that patient's going to have great pain relief. So in still, what does this look like? Well, you can see the needle coming in here from the side over the AIS and making contact with the pelvis behind the psoas tendon here, illuminated with a star. You'll see it just happens ahead of the iliopubic eminence and somewhere just typically a little bit lateral to the femoral artery. Once on the right side of the image, once the injection is complete, you typically get a pool of local anesthetic that's pushing the tendon up and laterally, with the local anesthetic pooling a little bit medially, although this can be variable. So, indications for the PANG block? Well, you've got them up there. What's our target? Again, it's the psoas tendon, and it's the ilium just behind the psoas tendon. You want to deposit your local anesthetic just there. I typically use somewhere between 20 and 30 cc's. And the outcome is going to be a fantastic sensory blockade without any motor disruption. So moving on to the erector spinae plexus block. So we see a lot of chest pain in the emergency department. And I'm not talking about chest pain like ACS. I'm talking about chest wall pain. I'm talking about rib fractures, zoster, chest tubes and pneumothoraces, and breast surgery pain. The erector spinae plane block is easy and it performs exceptionally well for chest wall pain. There was a fantastic small study in the Canadian Emergency Department for patients receiving the erector spinae plexus block for acute chest wall pain from rib fractures. And on average, it decreased their pain 7 points on a 10-point scale. Importantly, again, the expectation here is not surgical grade anesthesia. So don't go putting in a chest tube with the ESP block alone. The classic description of this block is at T5. And as you can see from the image on the screen, it covers a tremendous area of the chest wall. However, there are increasing indications in the abdomen and lumbar spine for things like pancreatitis and renal colic. So how does it look and what's our anatomy? Well, when you insert the needle, this is a cross section of the thorax at the 5th vertebral vertebrae. You insert the needle. and make contact through the ESP muscle with the transverse process. So the plane we're looking for is the anterior part of the erector spinae muscle, and where it makes contact with the posterior part of the transverse process. An injection here anesthetizes the dorsal rami as they traverse this plane, providing anesthesia to the adjacent muscle and soft tissues that contribute to the posterior chest wall. Additionally, local anesthetic here into the erector spinae plexus or erector spinae plane spreads anteriorly, anesthetizing the ventral rami where they become the intercostal nerves. The intercostal nerve anesthesia provides analgesia directly to fractured ribs, the periosteum, the lateral anterior and anterior chest walls by anesthetizing the lateral and anterior branches of the intercostal nerves. Cephalocaudal spread in the channel-like erector spinae plane extends the anesthesia somewhere between 2 and 3 levels above the level of injection and 3 and 4 levels below the level of injection, resulting in a tremendous spread of local anesthetic and analgesia from a single shot. So how do I find the right landmarks? Well, when you put the probe in the coronal orientation along the spinous processes, you'll see the views that we can see here below. So what you'll see when you put the probe on the patient over the spinous process is very near to the surface, a hyperechoic spinous process. It's the closest bony landmark to the edge of the thorax in the thoracic spine. When you move just a little bit, it produces a great hyperechoic reflection. When you move about 2 to 3 centimeters laterally, what you're going to see is a little bit deeper, this transverse process. These still produce an excellent bony reflection back to the ultrasound probe. And above it, you'll see the erector spinae muscles, as well as some of the muscles of the thorax, like the trapezius and rhomboid muscle. This is your target. And I kind of think of it like a plateau in a geography textbook, where you have steep edges on either side and a very flat top. When you move even more laterally, you'll see the ribs coming in from down below. The ribs have a bit more of a C shape, and they're facing away from you. There's the response back of the rib periosteum back to the probe is just a little bit less bright. There's a lot more intercostal muscle in between the ribs, and in the far field, you're going to see the pleura moving with lung motion. So when you scan back, you'll see the transverse processes come back into view with a little bump up, a very flat and excellent reflection back to the ultrasound probe. And this is our target with the erector spinae plane block. So in still, this is what you can see here. You can see the erector spinae muscle with some of the other muscles lying on top, the transverse processes labeled above. You can see the block needle coming in from left to right and then lifting up the erector spinae muscle with a bunch of local anesthetic. So how does it look in real time? Well, this is it. You can see the needle coming in from the right side of the screen here and making contact, just going through the erector spinae muscle and just making a little bit of contact with the lateral edge of the transverse process. This is a very skilled needle operator. And so they're raising a small bleb of local anesthetic to lift up the erector spinae muscle and move their needle forward into that little bleb of local anesthetic. They insert more local, that lifts the erector spinae muscle up and away off the transverse process, and you get great spread, lifting the whole muscle up and away from the chest wall. When you're done, you can just withdraw the needle. So our indications for the ESP are on the screen, and our target again is the transverse process below the erector spinae muscle at about level of T5, or typically, if for other places, at the level of the pain. And that way you can expect sensory anesthesia about 2 to 3 levels above and 3 to 4 below. So you've covered yourself. I typically use somewhere between 20 and 30 mils of 0.25% of bupivacaine with epinephrine. And what you get is a great sensory blockade of large portions of the chest wall. No talk on regional anesthesia would be complete without a last slide. I'm talking about local anesthetic systemic toxicity, and that happens in about 1 in every 1,000 cases of a large plane block like this. POCUS guidance dramatically reduces the probability of LAST. We tend to think of it as a prodrome followed by CNS and then finally CVS features, but importantly, it can prevent with any one of these symptoms. So how do I avoid it? Well, I use local with epinephrine because typically you can see the epinephrine before you see the toxicity from the local anesthetic. Inject slowly and aspirate frequently. You want to monitor for change in vitals if the patient's hooked up to monitors, like an elevated heart rate or blood pressure. And last but not least, throughout these processes, I'm talking with my patient constantly about the signs and symptoms of LAST and discussing them with the support people in the room. For big blocks, make sure you dose your anesthetic on lean body weight. A lot of the patients we want to use regional anesthesia on in the emergency department are predisposed to bad outcomes from LAST. So I'm talking about the extremes of age, low muscle mass, comorbidities, and high doses of local anesthetic. If you encounter it, what do? Well, you stop the injection, call for help, and call for a last kit. Support the airway because acidosis takes the local anesthetic into the tissues where we don't want it to be. If they're seizing, give them benzos, and then a lipid emulsion. What you want to do to dose this quickly and easily is to give about 100 cc's over the first minute, 200 cc's over the next 20 minutes with PRN boluses of 100. You want to continue the infusion beyond 10 minutes after the last symptoms have resolved. Importantly, propofol is not a substitute for lipid emulsion. So some handy resources. Well, the Duke Regional Anesthesiology and Acute Pain Medicine YouTube channel is awesome. It is filled with kind of 5 to 7 minute videos that go all over so many different types of blocks. It's unbelievable, and exactly how you can perform them, your sono anatomy, and what you can expect as outcomes. There's also the Nerve Block app available for iOS and Android. It has a bunch of really great little tutorials about how to perform particular nerve blocks, what you can expect for the action, and side effects you can expect. If you're more of a text and still image-based person, the Highland EM ultrasound website is excellent. It has very concise summaries based on different blocks with all kinds of different summary documents and nice still images that will tell you all about what to expect. These are my references for the presentation. And with that, I'm going to hand it over to Dr. Talia Burwash-Brennan for her presentation on MSK ultrasound.
Okay, fantastic. Thanks so much, Dr. Bell. That was a great talk. Thanks for clarifying what those acronyms mean. And thanks for sharing with us the fact that you seem to like acronyms more than you like regional anesthesia. So our last presenter today is Dr. Talia Burwash-Brennan. She will be talking to us about how we can use an MSK POCUS guided approach to evaluate joints and tendons. Dr. Burwash-Brennan completed an emergency ultrasound fellowship at the University of Ottawa. She currently practices emergency medicine in Montreal and is a lecturer at UDM. She's also the communications lead of the CAEP Emergency Ultrasound Committee. Take it away, Talia.
Thank you so much, Dan. All right, so last presentation of the evening, and I'd like to thank you for having me speak. Today I'll be talking about point of care ultrasound of joints and tendons. And at the end of the session, you should be able to describe how point of care ultrasound of tendons and joints will benefit your practice, identify a torn or ruptured tendon on POCUS, identify a joint effusion on POCUS, and last, be able to clinically integrate your POCUS findings within the clinical context of the patient. I have no conflicts of interest to disclose. And before going into some cases, let's talk about the why. Why should we perform point of care ultrasound of tendons and joints? So the first main point is that the diagnostic accuracy of point of care ultrasound to detect complete tendon ruptures is, if not the same, is the same, if not better than the physical exam. So as you can see here, the sensitivity is 100%, but the specificity for POCUS is actually quite a bit higher. In terms of POCUS to detect joint effusions, as you can see here, POCUS way outperforms the classic physical exam to detect joint effusions. In terms of other utilization of POCUS for imaging of tendons and joints, it also has been found in a recent study that point of care ultrasound of tendons and joints can actually reduce the need for procedures, in particular unnecessary procedures. So in this study, they actually saved 134 procedures out of 234 exams just by performing point of care ultrasound. Last, point of care ultrasound of tendons and joints can improve your success of arthrocentesis. So an ultrasound guided arthrocentesis has an extremely high success rate compared to the classic landmark approach. So let's go into some cases. So the first case is a 20-year-old man, a varsity tennis player. He was walking or running rather, and felt a snap posterior to his ankle. On exam, there's some mild swelling to the posterior calf, no palpable gap, and his Thompson test was normal with plantar flexion noted. You perform a point of care ultrasound, and this is what you see on your ultrasound. So with that, and you may be right now saying, well, I don't know what I'm seeing, and that's okay. We'll talk about it in a few minutes. With what you see though, how would you proceed? And we'll talk about that at the end. So would you send the patient for an ankle x-ray? Would you consult orthopedic surgery? Would you ask for radiology performed ultrasound? Or would you immobilize in plantar flexion and send to orthopedic surgery as an outpatient? Let's talk a little bit more about tendons on ultrasound. So tendons on ultrasound have this fibrillar appearance, in particular in the longitudinal view. And this is the biceps tendon there in the longitudinal view. The short axis tendons tend to have more of a speckled appearance, as you can see here on the right with the biceps tendon. As Colin pointed out, tendons have this property in which they can have anisotropy. So that is that depending on the angle of incination, the tendons can appear more hypoechoic. And so when imaging tendons, you may actually think that you're seeing a tendon tear or rupture, when in fact it's just anisotropy. So a way to avoid that is change your angle of incination, and then also you can elongate the tendon to have a better view of the tendon itself and avoid anisotropy. When talking about the imaging protocol for the Achilles tendon, so as you can see here, you want to start distally, have the probe distal to the posterior calf, and then slide proximately. You also want to move your probe into the transverse position and image also the Achilles tendon in the transverse position. One important thing to do when imaging any tendon is to provide dynamic imaging. And what that means is by dorsi and dorsiflexion and plantar flexion of the tendon, you will see the tendon moving and certainly be able to detect a rupture more easily, and also detect if it's a complete or partial tendon rupture. The anatomy, so just when you go to image your Achilles tendon, you'll see on the far right the calcaneus. Just coming off of that, the Achilles tendon, you'll see the Kager fat pad, the soleus muscle, and then the gastrocnemius muscle. And the longitudinal view, if we're going to image an Achilles tendon rupture, here is a nice example of that. So we're sliding from the calcaneus, moving proximately, and then we see a hypoechoic region with some heterogeneous material in there. And that is indeed an Achilles tendon rupture. Here's part of the tendon, there is the other part of the tendon, and there's that hypoechoic fluid, likely some blood in there as well. Moving in the transverse view, as we see sliding here, the transverse view can be a little bit trickier sometimes. As we're sliding up, if you look on the top screen there, you'll see the hypoechoic region, which indicates the tendon rupture there, the discontinuity of the tendon. So let's do a few cases. So is there a tendon rupture, yes or no? So here we see a hypoechoic region, and we see two ends of a tendon that in dynamic movement are not moving together. So yes, indeed, there is a tendon rupture. Looking here as well, in this case, do we see a tendon rupture, yes or no? We see as the dynamic imaging is performed, just the distal part is moving, not the proximal part. And so going back to our case, we had a 20-year-old man, varsity tennis player, pain to the posterior calf, but a normal Thompson. And that's not surprising based on this imaging. As we see here, he has a partial Achilles tendon rupture. So we do see translation of the movement of the Achilles tendon across that kind of little bit of Achilles tendon that is still attached. So by moving or by performing the dynamic movement, we can see that it is in fact a partial rupture. So how would that change? Well, in this case, we may choose to immobilize the patient and send urgently to orthopedic surgery as an outpatient. As certainly in this high-level athlete, they may still operate on a partial Achilles tendon rupture, but we certainly do not need to keep the patient in the emergency department. So next case, we have a 62-year-old female who fell on the ice into a snowbank. She's pain to the left knee anteriorly. On exam, you note she is a quite morbidly obese patient, so the exam is quite challenging. There's swollen left knee. You do not palpate a gap, but you find that she's unable to extend her left knee, and there's quite significant pain with attempting to extend her knee. You perform a POCUS. And this is what you see. So given that, would you place the patient in a neomobilizer and have urgent outpatient orthopedic follow-up? Would you place the patient in a neomobilizer and obtain a radiology performed ultrasound in the emergency department? Would you send for X-ray or CT the knee? Before we answer that, let's talk about the quadriceps tendon imaging protocol. So much like the Achilles tendon, you want to start distally. You want to identify the patella. Then next to the patella, coming off of that, you'll see the quadriceps tendon. You'll see the prefemoral fat pad, and then you'll see the suprapatellar recess. You want to slide along the quadriceps tendon in the longitudinal view and then also in the transverse view. Looking at an example here, this is in dynamic imaging. So we have the patient extending and flexing the knee, and we're looking for that tendon rupture. And indeed, we do see it here. So we'll go back to our case that we just talked about, the woman who fell in the snowbank. She has pain, really a challenging exam. As I said, quite a large body habitus, difficult to assess the tendons, but when you perform your POCUS, well, the answer seems pretty clear. As we see here, a hypoechoic region, discontinuity of the tendon, while it is certainly a quadriceps tendon rupture. So what do? We'll place the knee mobilizer and obtain urgent outpatient orthopedic follow-up. Moving on to our third case. So we have a 16-year-old male who fell off his bike. And on exam, you notice he has some pain and swelling to his left elbow, pain with flexion, extension, supination, pronation. We perform a POCUS of the left elbow. And this is what we see. On the left side is the longitudinal view, the right side is the transverse view. So given that, do you mobilize the elbow? Do you obtain an X-ray to confirm? Do you obtain a radiology performed ultrasound? Do you obtain a CT of the elbow? Do you discharge the patient? Or perhaps you do none of those. So we'll come back to that. But just to briefly talk about ultrasound of the joints, in general, you have two joints that come together to form a V. Around that, you have a hyaline cartilage, you have a fat pad there, and then you have the extensor tendons underneath your probe. In the longitudinal view, as you can see here, we have the humerus, the olecranon, we have our triceps muscle, and then we have the fat pad. If we rotate in the transverse view, you'll see your capitellum, your fat pad, and the triceps just underneath your probe there. So an example of an effusion on the elbow, you're going to look for a hypoechoic region within that joint space, within that V. So here you can see on the left, a hypoechoic region displacing that fat pad, and on the right as well. So just a few cases. So on the left here, do we see a joint effusion? And on the right, do we see a joint effusion? So on the left is the longitudinal view, on the right is a transverse view. And certainly we do see them. Here in this case, it's less black or anechoic, and it's more heterogeneous. So in this case, it's a hemarthrosis that we're seeing. So returning to our case, so on the left, we have that longitudinal view. And on the right, we have the transverse view. And do we see an effusion? And what are we seeing here? Certainly, we see an effusion in the joint space. And this was a trauma in a young 16-year-old male. So you're thinking, okay, is there a fracture? And we have a bonus view. We decide to look at the radius. And here, along the radius, we can see a cortical disruption. So we have the proximal radial fracture, and we have our answer. So based on that, we can immobilize the elbow, and we could obtain an X-ray, depending on the patient and your center. You could have a repeat X-ray as an outpatient, or just immobilize, given that it's likely an undisplaced fracture. But certainly your POCUS helped with that. Last case we have, 80-year-old female, immunocompromised, presents with right wrist pain and a history of fever. On exam, she has a swollen wrist, red, and painful to move. You decide, not surprisingly, to perform a point of care ultrasound. And this is what you see. So based on that, do you perform an arthrocentesis? Do you perform an ultrasound-guided arthrocentesis? Do you ask for a radiology-performed ultrasound? Or do you just start antibiotics empirically? Let's look, before we talk about that anymore, just in general, the anatomy of a wrist joint on ultrasound in the longitudinal view. So sliding distally from the radius on your exam, you'll come into view of the radius, the lunate, the capitellum there, or the capitate rather, and the extensor tendons. A wrist effusion on ultrasound will again be a hypoechoic region. And you see here within the joint space, that hypoechoic region as outlined there. So another case, is there an effusion or not? So what do you all think? It looks pretty convincing for an effusion within that joint space. So returning to our case of our woman with a fever and wrist pain, do we see an effusion there? Well, certainly it looks convincing for an effusion. So based on that, what would we do? Well, in this case, I would recommend performing an ultrasound-guided arthrocentesis. And if you attended CAEP, you might have seen my presentation on ultrasound-guided arthrocentesis. If not, I recommend you checking it out. And that takes you through how to perform the procedure using ultrasound to increase your success rate of the arthrocentesis. So in summary, I recommend utilizing POCUS of joints and tendons to improve your diagnostic accuracy, reduce the risk of unnecessary procedures, and increase the success of procedures, namely an ultrasound-guided arthrocentesis. I also recommend using POCUS to identify a tendon rupture on POCUS. A tendon rupture, as we saw, is a hypoechoic region with a discontinuity of the tendon. But just beware of anisotropy that could lead you astray. Also recommend to look for an effusion on POCUS to help with your differential. It is a hypoechoic region within the joint space, as we saw. And last, remember, like our cases showed, it's important to always consider clinical integration with any utilization of POCUS. So these are my references, and I look forward to any questions you may have.
Thanks so much for walking us through the why and how of using MSK ultrasound. And a huge thank you to all three of our speakers. They were all fantastic talks. We should have about 15 minutes left for questions. So please allow me to start with a question for Jillian. So someone has asked, what is the probe position for ocular exam?
That's a great question. So if you're using a transducer that has a probe marker, typically we would start in the transverse view with the probe marker towards the patient's right side. And you want to generate an image in that plane. And then again, you want to change the position of the probe to longitudinal, so you get a sagittal view of the eye as well. The probe marker then would be towards the patient's head. There's a really, really beautiful infographic from www.pocus101.com that has a really nice picture that shows you exactly that technique.
Oh, wait, perfect. I think that hopefully helps clarify things. Question for Colin. Are there any medical legal cases with regards to ED blocks or complications thereof?
So not that I've encountered. Actually, the only one I've identified and did a literature review for this for a project I was involved in several months ago. But there's only actually been one death reported from an ED block, and that happened because someone got opiates in the UK when they got a hip block. So nothing yet.
Oh, wait, so it sounds like we should be exercising some caution with patients who have received a considerable amount of opioids before actually performing the block. Question for Talia. Someone has asked, are you aware of any online resources for MSK ultrasound?
Yeah, great question. So certainly there are lots and lots of resources, depends what you're looking for. So if it's evidence-based, there's Ultrasound Gel, a great website to look at the evidence of using this. If you're looking for images, there's SonoShare, which is a wonderful resource. So really there's, I mean, certainly I can provide a list. I could go on. There's also, I have a book if anyone's interested in more of a hard copy as well. This is a great resource. It's detailed, but a really great resource if you're looking for more information. But certainly there's quite an extensive online compendium of resources as well.
I like that. You're taking us back to the past with the hardcover textbook. So what was that called? It was called Musculoskeletal Ultrasound. Was the editor Jacobson?
I can, yeah, if you can see it there.
Okay, John Jacobson. There you go.
Yeah.
Question for Colin. Someone has asked, can you use the ping block for hip dislocation?
So I haven't actually read of any, I haven't read a case report about that yet. I think it would work for, so this is just personal opinion, I think it would work for some analgesia, but it's not a motor block. So it's not going to help you really overpower those muscles in the same way that you want to. I certainly think it would be helpful definitely after you get it reduced in managing pain going forward. But I don't know if it would actually give you everything you needed to do to reduce a dislocated hip without any other form of analgesia.
Yeah, I agree. That probably makes sense. Question for Talia. So this participant, they've asked, in your experience, when it comes to interacting with your local orthopedics service, do you think that MSK POCUS could potentially replace X-ray? For example, would the ultrasound be sufficient to arrange for fracture clinic follow-up?
So great question. And I think absolutely depends on your center. Certainly in pediatrics, I think there absolutely is a role. And I think in collaborating with orthopedics in that respect, I think there's, or at least at my center, there's a tendency to be open to not providing X-rays or radiation to children. So I think in pediatrics, certainly in adults, the question is certainly if you're not going to change your management and if they don't need to see orthopedic surgery, you may decide not to do any further X-rays. But that being said, orthopedic surgery, they do want to look at X-rays and read X-rays when they have referrals. So at this point in adults, I have not personally referred patients without imaging. In pediatrics, I have.
Yeah, I kind of agree. I think our orthopods would be kind of ticked off if they got a referral for a patient for a fracture identified on ultrasound but had no X-rays. Really, I think that part of the issue is that we need to obviously be on the same page with our consultants with regards to communicating information like that. And I think for sure, the ultrasound scan is hugely informative potentially in terms of changing our immediate management or decision-making at the bedside. But it makes sense that you should probably get X-rays at a minimum, just so you can have like a sort of be on the same sort of level when you're talking to them in terms of conversation. Question for Jillian. If you are going to be sending the patient to the ophthalmologist anyways, why bother using point of care ultrasound?
Oh, that's a great question. I think really the answer is that it helps you provide a diagnosis. So, and while that's useful in urban centers, it may be even more useful if you're in a rural and remote center, if you have to transport a patient a fair distance away. So if you can send your image to the ophthalmologist along with your patient history and the rest of the exam, and you can agree that, the diagnosis is clear, you probably can wait if a patient simply has a posterior vitreous detachment, for example. Whereas if you clearly identified a retinal detachment, maybe with an associated hemorrhage, that patient needs to be referred a lot sooner. And in some larger centers, it may change who will see the patient as well. So I think it's a valuable tool. knowing how little I can gather from doing fundoscopy, I think it's probably the more useful tool I have for making a diagnosis for the patient.
Yeah, I agree with you. And I know that there's some health centers and systems locally where if you do identify that the patient has a retinal detachment, you're actually getting on the phone with the on-call retinal specialist and not the on-call general ophthalmologist. So it does make a difference in terms of your referral pathway, depending on where you work. Okay, so a question for Colin. Someone has asked, is there any role yet for ED regional catheters for continuous infusions or repeat blocks yet?
I don't, it depends on where you work. So there are places that are doing this, especially in the United States, specifically the Highland EM ultrasound website that I mentioned. That site is inserting peripheral nerve catheters for folks that are going to be there long-term, or people who have a history of opioid use disorder when they present with a substantially painful condition and are looking for something that's non-opiates when they're going to be admitted long-term. I definitely think there will be a role for these in the future. I don't know of anybody who's doing it in Canada, but I think that for patients who are going to be admitted for a long time, that there definitely is a role for here. And I think it's something that emergency physicians definitely have the skills to do and the knowledge to do. So I think it's one of those things that'll come in the future. But are we going to be using it all the time, every day? No, I think this is going to be kind of a once in every couple months procedure that we do. But they're not very hard to place.
And practically speaking, too, it depends on what sort of equipment you have. I mean, I think most emergency departments aren't going to have those specific types of catheters readily available. And, if you're under time pressure as it is anyways, you're not going to bother trying to find a specialized catheter that you have to get from a special area of your hospital. And then just a follow-up question for Colin about monitoring. What do you do with monitoring these patients during the procedure? Do you have to put all of them on cardiac monitors?
So that's a really great question. I think it's definitely a point of contention between the emergency medicine world and the anesthesia world. Practically speaking, I will admit, I don't have all these patients on monitors when I'm doing these. I do have all of them on monitors if I'm doing it in a room where it's just the two of us, or if there's not going to be anybody else in the room. So if there's someone the patient can talk to in the room, like a loved one, or a nurse that's going to be able to evaluate them fairly expeditiously in any case, I'm okay without monitoring that patient. If they're going to be in a room alone around the corner, no way in hell. I often find also that these patients, because they're typically waiting to go somewhere, oftentimes they're in hallways. And so there's lots of foot traffic going by. So I don't monitor all of these patients with cardiorespiratory monitors unless there's a substantial chance that there's going to be nobody in the room, or that they're going to, that they could decompensate and specifically hypoventilate or have last without anybody walking by.
So apparently Colin's happy with foot traffic. We have one last question that was asked before any of the talks even started. And I don't even think we touched on this topic, but, I figure since you guys are all experts, you guys can provide a bit of an opinion. So this question is, could you comment on the ease of access using POCUS for peritonsillar abscess drainage? They've indicated that they've had mixed success with this.
I can start by answering just because I have recently done quite a few. So I guess it depends. I guess mixed success, I'm not sure in terms of what that means, if it means not being able to drain the fluid, if it means with the patient cooperations. There's many factors, I think, to consider in having a successful ultrasound guided drainage. Also, so just to kind of talk about a few of them, one thing that I found useful is if it seems like it might be difficult or the patient's uneasy, I've had a resident or even another staff member come in with me to assist with holding the probe, and we've drained it together, or with the resident, for example. But I think the biggest thing to consider when doing the procedure is really what is the patient's comfort, because that's really the main I think, determining factor of how successful you'll be. So how much lidocaine have you put in? And what kind of patient are they? Choosing your patient, I think, is one of the important factors. Don't know if you want to add something there, Dan.
One of the things that I find is a bit of a challenge sometimes is getting the probe and the needle in the mouth at the same time. And so some people who have small mouths, it can be difficult to do both. So if you rotate your endocavitary probe and have the handle and the probe marker facing away from the abscess, it can be a little bit easier to get both the needle and the probe in at the same time. But some people, they just don't have enough real estate to really get to really truly guide it. And in that case, I try and get an idea of an ultrasound with a landmark and do kind of an ultrasound landmarked approach.
Yeah, I think one tip in terms of the actual endocavitary scanning is I often just tell the patient, put this on the part that hurts the most. And invariably, that's going to be where the abscess is located. So you can get a better sense of exactly how big it is, how deep it is, how far away the carotid is. Okay, well, that's fantastic. I believe we're pretty much close to the end of our session. So many thanks to our fantastic speakers for your educational presentations and to our audience for being actively engaged throughout. We hope you're inspired to start implementing some of these POCUS applications on your shift tomorrow to improve both your diagnostic confidence and to improve patient care. Keep well and continue doing what you do, because delivering excellent emergency care matters. Thanks for joining us. Have a good night, everyone.